Hello, good afternoon, everyone. Welcome to Talk on Health. I am Janiqua Palmer, and usually I do talk on race, but today we switched it up a little different. And as always, we're going to start with the land acknowledgement. The YWCA Lower Cape Fear serves the people located within the Lower Cape Fear region. This land once thrived with life from indigenous peoples, known today as the Cape Fear Indians and the Wakamasuan Indian people. Living in established settlements along the Cape Fear River and Lake Waccamaw, along with many other established sites in the region. We need to protect and honor the history of these places. Indigenous people are not relics of the past. They are still here, continuing to demonstrate their talents and gifts amidst a backdrop of ongoing colonialism and oppression. They are worth celebrating. We hope our land acknowledgement statement will inspire others to stand with us in solidarity with Native nations. And I would like to turn it over now to Mary Ann.
Thank you so much. We are absolutely thrilled to be here with the YWCA and Delta Sigma Theta. Thank you all so much for having us. I am now going to share my screen and commence my talk. The title of my talk is I Just Don't Do Doctors, Understanding the Health Needs of Aging Black Lesbians. This was research that was done a few years ago in collaboration with Georgia State University School of Public Health and Dr. Tonya Poteet, who at that time was at Johns Hopkins School of Public Health. She is our research partner, and she is now an associate professor of social medicine at UNC Chapel Hill. So a huge shout out to Tonya Poteet. I'm trying to advance my slide. And I can't seem to do that.
Did you try the space bar?
Yes.
Okay, try the arrows.
Did that and the space bar and the arrow and nothing.
Okay, try to stop sharing and
Okay.
then go to the next slide and then share again and see if that helps.
Okay. Let me try this. There we go.
There we go.
Okay. All right, thank you.
You're welcome.
Zambi Nobla, an organization that I am currently the ED of. It's the National Organization of Black Lesbians on Aging. It centers service, advocacy, and community engaged research. We are deeply rooted in Atlanta, Georgia, and we are committed to building a base of power for Black lesbians 40 and older. So with today's talk, hopefully when I have concluded, there are a couple of things that the audience will be able to take away. First, to be able to describe the common health concerns among Black lesbians who are over the age of 40, and to be able to identify some strategies to meet the health needs of Black lesbians as they age. So a bit about the background for this research. We know that older Black lesbians constitute a woefully understudied population in the United States. And there's a small and growing body of knowledge about LGBTQ health and aging, but people of color are often invisible in this literature. And when we reviewed the published health literature, there were actually no studies on aging that considered the intersections of age, race, sex, and sexual orientation on health, nor any studies that explicitly centered the health priorities of Black lesbians themselves. And the Healthy People 2020 website notes that data sources are limited for aging LGBT populations, and that research is needed if we're going to inform future health and policy initiatives. So let's talk about intersectionality. Many of us have heard a great deal about intersectionality coined by Black attorney Kimberly Crenshaw in 1989. And certainly a study of the experiences of older Black lesbians, calls attention to intersectionality. The idea that we each hold these multiple overlapping identities that informed our lived experiences. And any analysis of race, sex, or class must pay attention to other dimensions of marginalization. So without attention to intersectionality, we really risk erasing, ignoring, and distorting the lived experiences of older Black lesbians and other multiple marginalized populations. So what did we hope to find with this research? We wanted to really look at how do Black lesbians describe their experiences of aging versus how they anticipate aging. How do Black lesbians themselves describe their health and their healthcare needs as they age? How do they describe their encounters with healthcare systems? And what are the coping strategies used by Black lesbians? Really, what supports their resilience? All right, so what were our methods? How did we get these women to participate in this study? So Black lesbians 40 and older were recruited through networks of Black LGBTQ organizations. We recruited through Black queer churches. We also utilized social media. And, we really also talked to the key community stakeholders. They were really important in helping to advertise this study and helping to recruit for us as well. In order to participate, you had to be 40 or older, living in Metro Atlanta, and Metro Atlanta is comprised of about 32 counties. You had to identify as Black and are of African descent. You had to identify as a same gender loving woman, gay or lesbian. And the women received a cash incentive of $50 and transportation costs. And the focus groups typically lasted anywhere from 60 to 90 minutes. We've been asked countless number of times, why did you all include women 40 and older? 40 is young. And so a lot of people are actually puzzled by this. Our sampling frame did encompass both these midlife women at 40 and also older Black women, because we wanted to capture a comprehensive perspective of the needs of these aging interventions across these different age cohorts. And so we really included the perspectives of midlife women due to the various forms of oppression, stress, and these consequent health challenges that Black women face across the lifespan, because we know that they contribute to a shorter overall life expectancy compared to white women. I should note here that within 6 months of this data collection, 2 of our youngest participants had passed away. One who was 41 had a massive heart attack, and one who was 50 who lived alone was found dead, and the cause of death was undetermined. So let's dive a little deeper and see who these women were. The average age of these participants was 54 years old, with an age range of 41 to 91. And yes, we do have some Black lesbians who are 91 years of age who are surviving. The largest proportion, 27%, resided in the city of Metro Atlanta. Most of our participants identified as Black or African American, although we did have a small number who identified as Caribbean or Latinx and biracial. The vast majority identified as lesbian, 81 of the 100 women, and then followed by same gender loving, gay, and bisexual. Most of these women identify as Protestant. I think that we were a bit surprised that the next largest category was other. And the majority within that category specified that they did not have any religious affiliation. And because we are in the Deep South, we were a bit surprised by that. Although many of these women have migrated here from the East Coast, the West Coast, and other places. This was a very well-educated sample. Most of these participants had a college degree or higher. At least 84 of these 100 women had some college. And a little more than half of these women were partnered. And the most common marital status was never married. And about 15 of them had some divorce in their history. And let me add here that when we collected this data a few years ago, marriage equality was not the law of the land. And so it was not legal to be married in any country in any state in this country. And that may account for the fact that we had so many women who were unmarried. If we did the study today and asked that question, the results might be very different. In terms of the living situations, the most living situation was alone. A close second was women who were with a partner or a spouse. The remainder lived with family members, and just a few, maybe 6, lived with a roommate. I mentioned before that these women were highly educated, but $30,000 to $60,000 was the most common household income, and 13% of these women, even though they were highly educated, lived on less than $10,000 a year. Only 7 of these women reported being retired, and most of them were employed or unemployed. Let's talk about the Heft status. 20% of these participants were uninsured. And that's compared to approximately 13% of the general American population. Now that's a typo down there. It says 3%. There should be 13%, excuse that. And so of those with insurance, more than half of those were on Medicare, Medicaid, some other form of government insurance. We live in a state, Georgia, that did not allow folks who were not disabled or elderly to get Medicaid. And so that may account for the fact that we had so many women uninsured. About 2/3 of the participants reported their health as good or excellent, and only 1/3 of those with disability reported good to excellent health. And so we know that low self-rated health has been associated with subsequent mortality. So what were the types of disabilities? Well, 36% of our participants reported having at least one disability. Almost half the disabled participants reported a disability that affected their mobility, whether that was arthritis or chronic pain. The next most common disability reported was mental health, depression, PTSD, bipolar disorder, and many of the women who reported a disability, 10 of the 36 reported multiple disabling conditions. So essentially we had, 8 women who reported heart disease, 5 women who were blind or deaf, 25 with mental health, and 50 with the reduced mobility issues. So what were the qualitative themes that emerged from this research? Our analysis produced 6 themes that were related to suggested characteristics of interventions to promote healthy aging among Black lesbians. Some of these themes focused on particular emphasis of interventions like economic support, while others highlighted critical skills and characteristics of individuals who run interventions. Some women reported that they love to see someone identified as a Black lesbian running some of these programs and some of these interventions. One of the most salient issues that emerged from this research from these women was the need for holistic mental health interventions. A lot of these women felt like they were not acknowledged when they go into these facilities, that they did not have much social support, they didn't feel welcomed, and they didn't feel as though they had access to competent services in their communities. Many women historically expressed a mistrust of mainstream healthcare. And because of the other factors I mentioned, not feeling welcome, not feeling seen, not feeling heard, they actually delayed care seeking in many instances. And they relied instead on natural healing and on spiritual healing as well. Having said all of that, many of these women are very resilient. They are survivors. They do have support from their partners, from their social networks, from their communities. They use spirituality as a stress reduction. They use laughter. They use dance. They use sexual expression to help mitigate some of the stress that they feel. So in summary, this was a well-educated, higher income sample of Black lesbians in an urban center in the South. Many of them were unpartnered and almost 1/3 lived by themselves. 1/5 was uninsured and more than 1/3 was disabled with multiple disabilities common. And there's an urgent need to address these physical health and mobility issues, as well as mental health, both preventive and therapeutic care. And we do know that the community does foster coping and resilience through these social support mechanisms. What are the implications of this research? One, that we need to train more pipeline and current mental health providers, that we need to increase the number of LGBTQ people of color who are trained to provide mental health services, that we need to develop and test innovative holistic care models and have them out in the community where people can actually access them with links to culturally competent facility-based services. And we really need to increase the opportunities for networking and social support through these online and in-person interactions that focus on these spiritual expressions as voiced by these women, and also these techniques to include music and dance and sexual expression and laughter, and to just develop some kind of innovative models of care. And so I want to thank the board of directors of Zami Nobla, again, Dr. Poteet, and most importantly, the 100 Black lesbians who gave of their time, their energy, and their honesty so that we can learn from them. Thank you so much for listening. Okay. So what I am going to do now, I will be happy to take questions during the Q&A if anyone has any questions based on this data set. What we're going to do right now is we are going to engage the panel, an amazing panel, I might add. Before we do that, because I am introducing 3 members of Zami Nobla, Mia McDonald, who is our PA, and it is very important that she's here today. She is going to introduce herself. Mia.
Thank you, Marianne. My name is Mia McDonald. I am an emergency medicine PA. I live in Greensboro, North Carolina. I also identify as a lesbian. I use she, her pronouns. And I currently serve as the Vice President of Membership and Development on the GLAMA Board of Directors, and I'm the immediate past president of the LGBTQA caucus. Thank you, everyone, for having me here today.
Thank you for being here. So it's my honor to introduce these stellar women, these stellar members of Zami Nobla. First, I am going to introduce Stahamili Mapp. Stahamili resides in Brooklyn, New York. She attended Fordham University, where she majored in natural science and Black literature. So she uses both sides of her brain. And she also earned an MS degree in cell biology. She continued her education at Teachers College at Columbia University, where her research interests centered on tools and strategies employed by successful learners and students of science. As an adjunct professor, she taught biology, nutrition, genetics, science and human values, botany and physics at various institutions. Stahamili currently sits on the boards of Zami Nobla and the LGBT Kwanzaa community of New York City. She is a member of the steering committee of Black Writers Conference at Medgar Evers College, CUNY University, and the Out FM Collective, WBAI, Pacifica Radio in New York City. Stahamili Mapp. Next, we have Angela Denise Davis. Angela is an ordained minister and an ukulele teacher. She is the founder of Griot, a program that offers ukulele music instruction. Angela's ministerial work focuses on the fusion of art and spirituality. She is also the creative director of Zami Nobla, where she is the creator, host, and producer of the Zami Nobla podcast and directs the community music program UKN. She is a graduate of Clark Atlanta University, where she earned a BA in art. She also holds a Master of Divinity from Vanderbilt University Divinity School and a Master of Science in Rehabilitation Counseling from Georgia State University. She is a Level 1 certified teacher in the James Hill Ukulele Initiative Teacher Certification Program. She might be Level 2 now, I'm not sure. And last but not least, Iris Rafi, a longtime resident of Atlanta, Georgia. Iris holds a BA in biology and English from Spelman College. So she and Stahamili has something going on here. Iris holds a PhD from Emory University and has spent many years teaching college courses in English writing and literature. She is presently semi-retired and works part-time for Grady Senior Services. Dr. All right, so let's get started with this conversation. So you all heard the findings from this mixed method research project that Zami Nobla conducted with Georgia State and Johns Hopkins. And I'm wondering, based on your identities as an older Black lesbian, what do you want your healthcare provider to know in order to best partner with you? And that's for each of you. We'll start with you, Angela.
I think that's a very important question because I find myself at intersections that require me to sometimes be more vocal about my needs. And that's the fact that I am not just an older, aging Black lesbian, but also that I am legally blind. And so when I encounter individuals within the medical profession to be a partnership with me for my health concerns, I need them to know both of those things succinctly, and that how they come into concert with my getting best care. So for me, when I go into a setting and I can't get visual cues or I'm sent some information that I have to have somebody read, it can be kind of frustrating. And so one of the first things that I need for that health provider to know is I need something that's accessible. And if you give me my paper or new patient form first, I need to be able to take it home and fill it out and then bring it with me, because I've had instances where I've been in the waiting room and someone comes out to assist me and they're asking me all these personal questions about me. And because I'm out, I'm not concerned about the ones related to my identity as a Black lesbian. But there is something about having to be in a waiting room with other people, hearing all about your health information, and you don't know anything about theirs. So I think the first thing is I need them to know is, with regard to who I am as a Black lesbian and other specific points of my identity, I need to have as much right for privacy and its accessibility as the other patients, because I don't necessarily want to be in a waiting room telling people all of who I am. I want to have the respect that other people would have. So that's very, very important for me, for that healthcare provider to provide accessibility. I think I also need, and these will go in concert, I also need someone to understand that I wanted to be treated just as anyone else would be treated. And so for me, when I look at healthcare forms and I see information about issues regarding to gender or your partner status, it's very clear to tell whether or not that healthcare provider is, I don't know what's a hip, but up to date certainly on how to create forms that are inclusive. And so when I see that, when I see inclusive forms, when I see images on the website, or I see other information about this practice where there are pictures of diverse people, and it seems like they are open and welcoming to all, that means a lot to me. So if I don't get a sense that that clinic or that provider is open and certainly accessible, then it really puts me at a negative place. Fortunately, a lot of my healthcare needs now are being serviced by individuals I know who are queer, and that's a real blessing here in Atlanta. I have not had that in the past. So a lot of my frustration and anxiety has been alleviated now with the healthcare professionals I have now who are clear about the Black lesbian piece. Even though that sometimes that accessibility piece is not there, they're clear about who I am as a Black lesbian. I don't have to school them. And so for me, that's important. I don't want to have to school someone about sexual identity or disability.
Thank you, Angela. Iris?
Well, yes, good afternoon, everybody. Some of what Angela said is also pertinent to me, certainly the not desiring to have an entire part of a healthcare facility knowing your all your personal business. So, and also I think I'm always kind of on guard about being referred to by my first name, because I think that immediately establishes a different type of relationship. And what I want to have is a more respectful, professional relationship, as opposed to, my friends call me by my first name, my contemporaries call me by my first name. And I found in several decades of dealing with healthcare, and at a time when I even worked in the healthcare system, I've noticed that tends to be both racial and cultural, and that many Black institutions, be they clinics, hospitals, or whatever, the people working there will tend to refer to other Black people by their last name. I've worked for several years back when I was in college at both Emory Hospital and Grady hospitals here in Atlanta, and I noticed that with Grady's especially, they refer to anybody over the age of 18 by Mr. or Ms. and last name. So that's something that I'm always cognizant of, and I correct whenever I think that somebody is, referring to me as Iris. I change that. Another thing for me is because I had suffered some serious setbacks medically in terms of my mental health about 4 years ago, and also economic setbacks. I had to not get my primary care or primary physician care, as well as other health care, from a private doctor, but from Grady or the Grady system. And that means for me, generally not having you don't always get that continuity which you would have with a private doctor. So I'm always making sure that every time I have a new physician that comes on board or whatever, I let them know that I'm coming from these different vantage points and from these different identities as a Black lesbian, as an older Black lesbian, and as one who has lived with mental health issues for a good many years now, something like 30 years of my life. And so that's always something that's there, and that's always something that I try to keep again, as part of how I deal with different healthcare providers, so that they know who I am and they know what particular experiences in life have basically brought me to where I am. So yeah, and I think it's another thing with the mental health, of course, is just the resistance sometimes, and also I found a kind of curious, no, I guess it's not curious, but certainly a surprising lack of knowledge on the part of many healthcare providers who don't always get it. I remember maybe 4 years ago when I had a suicide attempt. And I remember actually this was a nurse who said, "I don't understand that. You have a lot to live for." She didn't understand. So this person, as a health professional, did not understand mental health illness, mental illness. So that's something I've had to work constantly with as well. So yeah, it's better because Grady overall as a system is better than it was certainly when I worked there back in the 70s and the early 80s. And so that's a positive, and I like that they're moving in that direction. So yeah. Mm-hmm.
Thank you, Iris. Hamili?
Okay, so yes, I think for health professionals that I'm looking for is for them to understand that I am not going to be a passive consumer of healthcare, that I am going to be actively concerned and interested in every aspect of what they're providing. Yes, I am a consumer, but I'm a knowledgeable consumer. And I will spend time researching, doing background information. And when I'm spoken to, I want that provider to acknowledge that I am not coming here because I have free time to complain or that I am necessarily seeking attention, that I'm actually wanting to discuss in a logical manner what I'm experiencing and what the treatment will be. And when I do ask a question, I expect an answer that satisfies those things for me. So any provider that cannot spare the time or have the interest in having reasonable dialogue with me around care that he or she is providing, as well as medications. They can't, if they don't have the time or the interest to do that, then I don't want to interact with those people. I find that difficult. I also am looking for a provider who is not challenged by the fact that I have knowledge, scientific background, and science knowledge. Mm-hmm. Many providers are challenged, and I think they think, oh, I'm going to get sued here, or, she knows too much, and I can't give the usual BS line and satisfy her. And they may or may not want to do that. Also, I noticed that many practitioners that are associated with larger institutions, hospitals, et cetera, they themselves, their employment is contingent upon how many patients they see within a given period of time. So that there's like a mad rush to get you in and get you out, which really doesn't leave them adequate enough time for me to have a reasonable conversation often with them. And I guess I'm old school, that can have its pluses and minuses when you do get that professional who's willing to sit and talk, because if they're doing that with you, then chances are they're doing that with their other patients too, which means you may be sitting in that waiting room for quite a while. And that, that's a very old school experience I've had with those doctors who took the time to know their patients and give their patients adequate attention and interest. So it's a trade-off, which I don't necessarily love, but if I'm gonna ask that of them, then I have to be willing to be patient, which is technically what my cultural name means. Dahamili means patience, so I have to learn to live that. But I think that's like the overriding thing, in terms of sexuality. Again, as Angela, I'm glad if I don't have to explain things in detail, but I will if I have to. I don't mind, I don't mind the education process if it's going to benefit my care and benefit someone else's care. But I also look for a profession who understands that, whether you're partnered or you're not partnered, as a Black lesbian, you are going to need the attention that you should have, and that's mainly what I want, a partnership with my professional. As I said, I'm not going to be a passive consumer.
Thank you, Sahamili. Mia, so you've heard from our esteemed panel. You've heard the findings of the primary data that we collected. And so I'm wondering, as a healthcare provider who is in located in Greensboro, North Carolina, who works in emergency services, who comes in contact with all types of folk. What has been your experience with the LGBTQ community in a medical setting? And does some of what Angela, Iris, and Amelia have voiced resonate with you? Can you talk to us a bit about that?
Sure. So I work in the emergency department in multiple settings, both in an urban and then more of a rural setting. We work at 4 different hospitals located over about a 50-mile radius, and I treat patients across the lifespan. So any, newborns, sometimes we have babies born in the emergency department, all the way up until end of life. And I do see quite a few patients that are part of the LGBTQ community. We actually have a very large Black lesbian population in Greensboro, whom I see either as patients themselves, if they are parents and bringing a child into the emergency department. So from my perspective in the emergency setting, we're very fortunate with the advances that we've made through the electronic health record, so that some of the concerns, right, about having to really share some of your information, especially, talking about in the waiting room and some of these accessibility forms and making sure that all of your information is obtained, right? So some of that can cross over. And now we can even cross over from system to system. So a lot of times I can get information from other healthcare systems such as Grady. So if there are pieces of your information that you don't readily want to continue to share over and over, a lot of times we actually have that accessibility to be able to pull that in, which is very nice. Also from a form standpoint, you don't have to keep filling it out every time you come in. Now, of course, there's always the concern that something could have been entered in incorrectly, right? So we have to go back and trust but verify. So that just even the improvements we've made over the last few years have been huge. Now, I think that from my perspective, there are some times where a patient's sexual orientation and gender identity are very, very pertinent to the care that I provide in the emergency department. There are other times that it is just not. And if you're asking questions regarding if someone identifies as a lesbian and they're there for a sore throat, it's just kind of inappropriate. So even myself as an out lesbian, communicating with patients, that really only comes up to disclose my status if it's going to be in the best interest of the patient. And I think that we have a lot of clinicians that work with me in the emergency department, right? And I can even speak for several primary care clinicians, that there's always the struggle of looking at data that we've collected over the years, right, in different research settings, but also remembering that even though you have someone that may be a member of a community, that there's still an individual person that you're treating at the end of the day, and no two people's experiences are going to be the same. I want to make sure you don't have any additional follow-up questions, but yes, I have lots of experience working with LGBTQ patients across the lifespan.
Thank you for that. Before we go to the next question, do any of you have any questions for Mia regarding what we just talked about? Okay. So one of the issues that came up during the research that we collected was this need for cultural competency, or as I like to call it, cultural humility, and making sure that there is consistent training across the medical profession, that there's just not a one and done. Sometimes people think, oh, I've had one training, I'm good, I don't need anything else. And so that's one thing that I want to put a pin in. The second thing is from our panelists, how important is race, age, sex or sexual identity, and gender to you when choosing a healthcare provider?
This is a very interesting question because what came to mind immediately when you asked that is the fact that I had a conversation with my doctor maybe 5 years ago, and it was very sensitive information and questions I had that I wanted to be in conversation with her about. And we talked about it, and I know that she's a lesbian, and I know that she's very sensitive and empathetic. And so when I talked to her about that, the issue I was having, I was just really excited that I had someone from a medical standpoint who could be in conversation with me. And it was clear to me that if she were not a lesbian, we would not have had this conversation, because I felt like she understood what it is I was talking about. So for me, because I've had an instance like that, and I know how important it is for me to feel comfortable enough to ask someone a question about my health or personal matter like that relating to my health. It's very important for me to have someone who is a lesbian physician. And so she's at the place retiring, and now I'm a little bit afraid because I don't want to think about not having the luxury, and I know it's a luxury, of having a doctor who's a lesbian, who understands. I don't have to teach her about things, or I don't have to, feel like I need to walk on an eggshell around an issue that's very important to me. So having her as a lesbian is important. It's been equally important in my search for a therapist. I've always wanted someone who was queer, not a lesbian, certainly within those alphabets, because I felt like you could really better understand where I'm coming from, and I don't have to school you. That's one thing I don't want to do. I don't want to have to teach somebody how to understand or how to be empathetic or how to have some humility around certain aspects of my person.
So is your physician, in terms of what's the ethnicity or the race, and does the sexuality supersede that, or does it matter? Can you speak to that?
Yeah, I think in this regard, she's a white lesbian, and I did not care that much that she was not Black, because she was white and well respected and trusted, and a lot of other lesbians in the community really appreciate her. I felt comfortable with her. If she had been a Black woman, that would be great. I've had Black physicians, Black women physicians who have been wonderful, but I would not have broached the conversation with them that I broached with her. So I do think that her sexual orientation superseded her race in this regard.
Thank you. Steph, Amelia, Iris, either one of you want to answer this?
Well, for me, Angela mentioned that her physician was about to retire, and she said how that's not desirable. And I remember for me, for about 20 years, from about 2000 but late 90s to, I would say, 2016, 2015, I was fortunate to have my primary care physician was a Black woman, and who I honestly, when she told me she was retiring, I remember telling her that's not possible. You can't do that. Because she was such a good doctor. She wasn't lesbian, but then nobody's perfect. But oh my gosh, she was absolutely great. She was intuitive. She listened, and basically, she was just fantastic. Learned all of the, I guess some of my little quirks and all that kind of thing, so that she knew, just basically how to approach me. Everything. So she was fantastic. But I also remember at one time, probably probably in the mid to late 90s, having all of my healthcare physicians actually being Black women. I had looked specifically for Black women, and I felt being very, very blessed in a way to be living in Atlanta, so that you could find that. And I wasn't necessarily looking for a Black lesbian, although, like I said, that would have been the icing on the cake. But at one time, my dentist was a Black woman, my gynecologist was a Black woman, my therapist was a Black woman, and my primary care physician was a Black woman. And as I said, that was probably not something that I would have been able to achieve in many other places in the country. And at the time, in my family, there's a history of mental illness. And at the time, one of my nieces who would have been in her 20s at the time, was really battling with bipolar disorder. And she's in Miami. And I remember my sister, well, she was actually a teen, more late teens, early 20s. And my sister really was having a hard time trying to locate a not just a Black doctor, a Black therapist or psychiatrist or psychologist, but a Black woman. Because she said she would watch her or she would listen to her as she talked about her visits with white physicians, and especially with white male physicians. And she would say, she would just say what they wanted to hear, and boom, you're on your way. And the one time that she was able to see a Black woman before that woman left the area, she said, she would always try that thing that worked out for her, which was that, oh, I'm doing so much better, and oh, I'm taking my medicine, and the woman just told her, no, you're not. Stop BSing me. You're not.
Mhm.
And so I looked for that when I basically left Emory, because at Emory I was fortunate again to have two Black women as my psychologists in the student service. And so I looked for that. And as I said, I was simply fortunate to find that for many years. I even went so far when my doctor came out of retirement and had moved further out, I believe Conyers, to a practice. At that time I didn't have a car, but I took 3 or 4 buses and trains and then an Uber to get to her, because she was that good. So it does make a difference, and many very often it makes a difference.
Thank you, Iris. So I'm conscious of the fact that I think we have about 13, 12 minutes left, and we have a couple of questions in the Q&A. And so I want to ask me a question, and I want to come back to Stehamili. So one of these questions is, how would you suggest building a relationship with a doctor? So let's just change doctor for PA, Mia. How would you suggest, as a person of the LGBTQIA community, building a relationship with a healthcare provider?
So I think that when you're looking to build a relationship with any clinician, I do think that it helps, if you can see maybe part of yourself in the person that is your primary care clinician, whether it be race, whether it be someone that identifies as part of the LGBTQ community. Unfortunately, there's not always, right? In some rural areas, there may be one clinician for the entire town, and so that may not be an option. But fortunately, in more urban and suburban areas, you have a little bit of flexibility, right? To find someone that may accept your insurance, that may have characteristics that you identify with. I think now as more clinicians have their bios posted on their webpage, or even on a health system's webpage, that if you live in an area where there are options, then you can find someone that may vibe with you, that may mesh with you, that may get you more as a person. And I would love to say that every clinician, is going to have this really personal connection with each of their patients. But I've experienced that personally myself, that's not always the case. But I think that with more information available, being able to kind of do your research as much as you would like to find someone that may connect with you is a good place to start. And it may not be until after you've met with someone and had a few appointments that maybe perhaps you don't connect on the same page, and you may need to look elsewhere.
Thank you. So Stehamili, Iris, and Angela, that Zaminoglu, at this point, we've collected 3 primary data sets. One on Black lesbians and aging, understanding healthcare needs, one on Black sexual minority women and breast cancer, and we're currently working on COVID-19 and Black lesbians. I'm wondering, Stehamili, is there any other data set that you would like to see collected from Black lesbians that you think is really vital right now, that we're missing the boat on?
Wow, that's a hard one. all having to do with some health conditions, you're saying, situation?
Well, it could be a particular
Mental health.
population. So for example, I was doing some reading recently around veterans. I mean, I'm not a veteran, but I noticed that there were a lot of women who were vets in our group. And if I remember correctly, in terms of LGBTQ people who had enlisted in the armed forces, the majority of them were lesbians. And so I would think it would be great to collect some data from these women, particularly around trauma, because so many of them seem to have experienced a lot of trauma in the military. A lot of them went to the military because they were not able to live out loud, and they felt like they could find the community there. So I'm just thinking, just in terms of different populations, that it would be great to be able to collect some data sets from lesbian vets around trauma that they've experienced.
I'm thinking, I think something that's of interest to me is the relationship, particularly with older Black lesbians and their family relationships, their familiar relationships in terms of support, not supportive, maybe how that's maybe changing. I sort of would like to look at that or see that from a intergenerational perspective, or maybe because we deal with 40-year-olds, that fits, that might be quite different. I'd like to see how that comports with, people that are in their 70s, 60s and 70s, and what their situations and their family relationships have been. Because I would hypothesize that some of us that are older have not had the level of support, I'll put myself in that category, that we would like in terms of emotional, physical, and maybe in some cases financial support, that because of our sexuality. So I'm wondering if that's changing, and if it's not, or if it is a problem, what are those parameters? What does it look like? What do people's experiences have been? What are their responses? Do they need to relocate? Are they more apt to relocate, move to other cities, live in areas? If they were in rural settings, live in more urban settings. What are they looking for to replace that, if they feel that they need to replace it? I guess those would be some of the social things I would be interested in.
Thank you. So we have 6 minutes. I'd like for everyone to answer this question. I guess we'll go out. Then we have a question in the Q&A. In what ways does it matter of being a lesbian when seeing a physician? I'm not quite sure what this question is alluding to, but you can answer it however. And Mia, I'm sure you also see a physician as a lesbian, so this is a question that each of us can answer. So what ways does it matter of being a lesbian when seeing a physician? That's the question. So however you interpret that. Angela?
Okay, well, the way in which I understand the question and what hits me first is, I think it's important to be in conversation with and this is how I'm thinking about this question in terms of just being out to your physician, being clear about who you are there. I think we talk about a lot of queer people, what we don't have is visibility. And what we so often choose not to do is to give voice. And so for me, being a Black lesbian, being in any type of medical care, when I show up in the fullness of who I am as a blind Black lesbian, it's clear they've had an encounter with me. And I think once you met someone, whomever they are, in their most authentic self, then the ground becomes larger beneath your feet, and we understand more about people. So I think that is an opportunity for the patient and the physician to understand that I've learned something more about the world, about the human condition, because I met someone who may or may not be different from me, who has a different way of moving in the world. And so it's very important that we show up authentically in whatever place we are, especially when it comes to healthcare.
Thank you. Mia?
So I think that probably the place where I feel the most vulnerable is when I have to go to the OBGYN, right? You're there in a paper top and maybe a paper blanket over your lap. And it's cold and it's very sterile. I think they're making strides to make that better, but that's the reality. And I remember I had an encounter back in 2010 when I was living in Las Vegas, where I went to see a white male OBGYN who asked me very personal questions to provide me with the appropriate contraceptive care as a lesbian, because he was not certain of what to recommend for me.
Yes.
And that is an example that I share with folks all the time, because I would never, ever want to have a patient walking away from an interaction with me where they felt as if they had to educate their clinician. And so now I have a wonderfully inclusive OBGYN. I had to unfortunately have a hysterectomy earlier this year, and the experience was vastly different. But I think it's just making sure that I'm not having to explain myself, especially in a very vulnerable situation.
Thank you. Iris?
I find that very interesting. I remember seeing and she was a Black woman, OBGYN, and I was having trouble with what do you call those things? Fibroids. And after an exam, she mentioned, what did she? Oh, she said, oh well, we talked about whether I would have a hysterectomy and that sort of thing. And she mentioned something. And then she said, well, because you're a virgin. I said, no, I was a virgin. I had not had sexual experiences with men, but I wasn't aware that I was a virgin. So yeah, I think sometimes you get a sort of disconnect. Sometimes if the physician or the healthcare provider is not, I guess, aware of that aspect of your life. So I think when we talk about being more comfortable or desiring or looking for a healthcare provider who is from the LGBT community, that sort of thing, then that's the kinds of things that we're concerned about. You know, the kinds of things where if they're talking about your family, they're not just talking about husband, boyfriend, that sort of thing, but they're talking about your partner. They're talking about, you know, other family members who may not be your children, that sort of thing. So those types of things do become important. They become very important. And not having a relationship that may not be a heterosexual relationship sort of diminished or not understood, and how that can affect your health, you know, and your well-being.
Sure. Thank you. Well, last week, a friend of mine went to the doctor, and the doctor asked if she needed a pregnancy test, and she said, "No, I'm a lesbian. I don't have sex with men. I haven't had sex with men in years." And he said, "You sure?" She said, "I don't need a pregnancy test." So he gave her the paperwork to go get blood, and what he had ordered was a pregnancy test.
Oh my God.
So clearly he did not believe her. He did not see her. He did not listen to her. He did not respect her. And so, you know, and I've heard that time and again about this pregnancy test thing.
Yeah.
So yeah. I don't know what.
You have to have sex. Yeah, if you're a woman, you have to have sex with men.
Yeah, exactly. You have to be at risk of becoming pregnant,
right?
No matter what you say. And you know, and I do understand that some doctors and the healthcare providers say, you know, it's the behavior, it's not the sexuality or the sexual orientation. But at some point, you know, if I've told you, then you have to. I want a physician, a healthcare provider who believes me, who hears me, who sees me, who respects me.
Exactly.
Stahamili, you have no time. It's 1 o'clock. Sorry.
I think you should have made this 2 hours, Marianne.
It wasn't mine. they didn't realize what a dynamic panel they would have, you know, of lesbians. And so you're right. They should have given us more than 1 hour. Yeah. And so I'm assuming that the YWCA is coming back to close us out. I'm not sure what the procedure is right now.
Anybody there?
Yes, I'm here. This was a very, very wonderful conversation. And it's definitely a conversation that I feel, you know, we're going to have to do a part 2. You ladies said so much. Definitely have to do a part 2. Well, you people, not just you ladies, you people, we have to do a part 2.
You lesbians is fine.
Okay, we'll have to have a part 2 for all the lesbians then. All right. Well, thank you so much for joining us, and everyone have a great evening.
Thank you.
Thank you.
Thank you for asking.
Thanks, everybody.
Bye.